let me switch back to Dr. Grayson for a minute to talk a little bit more about the therapy and also talk about a little bit more in general as far as asthma. We know that asthma is now described as having different phenotypes: allergic, eosinophilic, T2, non-T2, and on and on. Can you give us an understanding if this categorization is pretty accurate? And do you feel that the AERD is included in these terms?
Yeah, so that's a loaded question there. So I do think that the T2 high, T2 low, um, in general for asthma does play a role and is important. And so that's, whether there's TH2, IL-4, IL-5, IL-13 is the T2 high kind of model, IL-17, T2 low kind of model. The problem with AERD is it doesn't quite fit into that definition from a mechanistic standpoint. So when we're talking about, what is driving the disease, it tends to be more of the leukotriene, which are associated with sort of the T2 model. And when we talk about therapy, actually treating for T2 diseases will work. So it fits within that context, but the actual mechanism of why you have the sensitivity to the COX-1 inhibitors and stuff like that does not fit with a true T1 or T2 high, T2 low kind of model.
Right.
So I think that's kind of the difference. When we think about asthma more broadly, we tend to think of it in terms of allergic or non-allergic, and response to things in the environment. So in that sense, it is similar, that you would have the response to something like aspirin. But people that have AERD have severe disease sort of at baseline, even without taking an aspirin. It's just that if they take something like an aspirin, it very quickly leads to a very severe exacerbation. But often their disease is pretty severe just to begin with at baseline.
In preparing for this interview, I was looking up aspirin desensitization. Now, do you find that that's something or an aspirin challenge? Are these things that are done in these patients? Or?
Yeah, so there's when we talk about diagnosing these patients, oftentimes if you have nasal polyps, you have chronic rhinosinusitis, and you have asthma, it pretty much in itself makes the diagnosis of having AERD. But some people have, and they can tell you they took an aspirin and their symptoms got worse. But some people don't take aspirins, and they would never know, and so they'll have that, and in that case, it can be helpful to do a challenge with an aspirin, which we can do, and then see if their asthma gets worse. To be fair, if we're going to do that, usually we put people on a leukotriene blocker first, just to lessen the reaction so that it's more nasal upper airway stuff and less that we have a horrible asthma exacerbation in the clinic when we give them aspirin.
Right.
As far as the desensitization, that gets sort of to the idea of treatment. What's the best way to treat AERD? And it's really so the first piece of this, you want to treat the asthma, you want to treat the rhinosinusitis. So we do normal asthma treatments and things like that as well, inhaled steroids and long-acting bronchodilators, the usual kind of stuff. But for these patients, they respond very well to biologics. So we're talking about in primarily omalizumab, which is anti-IgE, mepolizumab, anti-IL-5, or dupilumab, anti-IL-4, IL-13. And actually, dupilumab tends to be the one of the biologics that seems to work the best. And those work to both get rid of the nasal polyps and also control the asthma. But if it works just as well as to do an aspirin desensitization. So this is an interesting thing where we actually give increasing doses of aspirin, start very low, give increasing doses of aspirin, and patients will actually have a reaction. Their lung function will drop. We can start at that dose and sort of move up, and we try to get them to the point that we're basically giving them sort of 2 aspirins twice a day. We can sometimes back off a little bit from that and keep them on that. And if we do that, we find that number one, they can tolerate aspirin. Number two, their airway disease gets much better, and it is much improved, as well as so both the upper and the lower airway disease. The only problem with aspirin desensitization is the fact that it doesn't make the polyps go away. So in general, if someone has polyps, we need to do surgery first, get rid of the polyps, then do aspirin desensitization, but then the polyps will not likely regrow if they stay on the aspirin. Whereas the biologics can make the polyps go away. So that's kind of a way to decide whether you want to do biologics or aspirin desensitization is, if you're not going to do surgery, then the only way you're going to get rid of those polyps is probably through the biologics.
Okay. So today we're mainly talking about aspirin sensitivity, but I'm curious, we know there are many other foods and additives that can trigger asthma. In fact, you mentioned some people, it's not aspirin necessarily that triggers their symptoms. Can you give like a high level view and maybe some resources for patients and physicians both who feel they have a patient with poorly controlled asthma that might be related to an unsuspected exposure?
Yeah, so asthma in general, not necessarily asthma with chronic rhinosinusitis and nasal polyps, but asthma in general can be exacerbated by many environmental exposures, pollution, strong scents, things like that. And so to try and understand what all those triggers are is an important piece of discussing care with your provider. In terms of what's available out there for people to look at and understand, I mean, the American Lung Association has not to be self-serving here, but does have a wonderful website with all kinds of information about clean air as well as the impact on asthma. Other sites that you can go to as well. Actually, there's several federal government sites. So the EPA has good information on it. The National Heart, Lung, and Blood Institute have a website as well that has good information about these environmental exposures. And then the Asthma and Allergy Foundation has information about it, and AAN also. So any of these patient organizations really do have a good list of things that you could potentially look out for and consider when you're evaluating a patient with asthma, or if you're a patient with asthma, thinking about, am I being exposed to things that are actually making my asthma worse that I could do something about in sort of cleaning up my environment and make my asthma better.
Got it. Now, aside from the aspirin challenge, do these patients respond to the other normal testing for asthma, like allergy testing, bronchoprovocation studies, FeNO, IgE? Are those all worth measuring in these patients as well?
So in general, they're really not. You can do them if you want, but in general, it's not. It's really is sort of the aspirin or the COX-1 inhibitor that's the problem. It's important to note that COX-2 inhibitors, that if they're pure COX-2 inhibitors, they're tolerated. Salicylates are often tolerated. It really is the COX-1, aspirin, ibuprofen kind of drugs that cause the problems.
Okay, thank you. So, Rhonda, I want to come back to you and having heard what Dr. Grayson said, maybe tell us if your experience has been about the same and tell us how managing your asthma has been going on over the years. You've told us about being prepared by emergency rooms, but on a day-to-day basis, what do you do for your ARDA?
Well,
AERD, I'm sorry.
thanks to my amazing medical team, my daily meds, which do include a biologic now, keep me very well maintained. Throughout my 22-year journey, I've obviously researched medicinal and non-medicinal therapies, and I have incorporated some of those things like acupuncture, a low omega-3 diet, infrared sonotherapy, red light therapy, and supplements along with regular exercise. But I do want to say to all your listeners, it is very important when you're looking at those kind of non-medicinal therapies that you discuss all of them, regardless of how insignificant they might seem, with your doctor, and which is something that I have done and continue to do. It's just because you just can't, this disease, there's some quirkiness with it, and sometimes you just don't know how maybe a supplement is going to play with a biologic, for a very simple explanation or something like that. So while I do all of these things, and I do believe that these things have been helpful for me and help in addition to my prescription meds to keep me maintained, I just can't stress enough about talking about these therapies with your physician.
Right, right.